All right. So good afternoon to the colleagues that have been very punctual. We're just going to give the rest of the attendees a few more minutes before we officially start. So I hope you don't mind.
Hi, Florian's having trouble joining. He says the link won't work. I think just maybe make sure you're adding him as the Sun email address, maybe. I'm not sure.
Did he register?
I don't think so.
You do have to register to be able to. You might have to register.
Well, I don't think I registered to join. Is someone able to like call him onto the call?
And Togo, can you add him on the call? Do you know how to do that? I'm just forwarding the link to someone who's asked.
Okay, let me try add him to the call.
Hello.
Hi, Florian.
Hi. Sorry for the technical difficulties. I couldn't use the first link. Can you hear me?
Yes, we can hear
Yes,
you.
we can.
Fantastic. Good. We're all set.
Yeah, great. So Florian, if you want to just see if your camera works and then we can get started, that's fine with you.
Yes, just a moment. This is, sorry, just a moment. Here we go.
Okay, great. So good afternoon, colleagues. My name is Priyashni Subraya, and I'm part of the TB Think Tank Secretariat. It is my privilege to officially welcome you to our webinar series as the TB Think Tank, showcasing not only work commissioned by the TB Think Tank, but also other important and groundbreaking locally produced research. As this is our first webinar, we kindly ask you to obey the usual virtual etiquette and please post your questions in the chat box, which the Secretariat will ensure are answered. With that said, I'm going to hand you over to our TB Think Tank Secretariat scientist, Jody Botha, who will introduce our topic and our speakers. Over to you, Jody.
Thanks so much, Priya, and thank you everyone for joining us this afternoon. Dr. Florian Marx is a senior researcher at SISIMA and the Desmond Tutu TB Center at Stellenbosch University. He coordinates the SISIMA DTTC Tuberculosis Modeling Partnership and Research Program and leads the working group for data analysis and modeling. He holds a PhD from Stellenbosch University and completed his research fellowship at Harvard and Yale School of Public Health. His research focuses on the epidemiology of TB and the public health impact of TB control interventions, with a particular focus on high incidence settings. He is also our very own chair of the TB Epi Modeling and Health Economics Task Team. Ms. Abigail de Villiers has a bachelor's and honors degree in biomathematics from Stellenbosch University and the African Institute for Mathematical Sciences, and a master's degree in epidemiology, for which she won the University Rector's Top Master's Award for her work on adaptive decision-making algorithms for spatially targeted TB screening. The work being presented today is based on her work with the Desmond Tutu TB Center, and she recently started her PhD at Heidelberg University Hospital in Germany, where she will look at modeling the impact and cost-effectiveness of novel diagnostic tests and strategies. Thank you both very much for being here. Over to you.
Thank you very much, Jody. Thanks for the lovely invitation, and good morning, everyone, or good afternoon, everyone. Thank you for joining us today. I'm going to share my screen. I think you have to make me a co-chair of the meeting or co-organizer. I can't share right now. Yes, thank you. Please let me know if you can see my screen.
Yes, we can.
Yeah.
Fantastic. Thank you very much. So again, good afternoon, everyone. The topic of this very first webinar is the assessment of healthcare service provision under the COVID-19 epidemic and the epidemiological impact of healthcare service disruptions in South Africa. And I want to say upfront, while we are presenting mainly focused on the modeling results today, there's a whole team behind this effort, including Mohammed Osman, who was chairing this effort, this assignment with me in total, Suan Mehan, Rory Dunbar, Annike Hesseling. So we are a whole team, and this work today is really the result of a whole team working on this. We had a lot of support also from Hari Moultrie, and we're focusing mainly on the modeling aspects of this assignment today. But like I said, that we're representing a team today. So just to give a little overview today about this assignment, we're going to talk about a little bit about the background of this work. We're going to give an intro to the methods and mainly the modeling methods of this work. And we're going to present results, important limitations, and then conclusions and some related follow-up work that we're currently conducting. Just to start, obviously everybody is aware of the substantial impact that COVID-19 and related measures to contain the spread of SARS-CoV-2 have had on healthcare services, in particular for tuberculosis. The COVID-19 response measures, everybody knows that they started in late March 2020 with the start of the level 5 lockdown, which included a restricted movement of people, mandatory mask wearing, and most importantly, also a lot of healthcare resources during this time were reallocated to fight or to mitigate the consequences of COVID-19. And then we also know that the lockdowns in South Africa were completely lifted on the 5th of April 2022. We're now hoping that we are past the pandemic, although there remains uncertainty around the evolution of novel strains and the potential of the epidemic of COVID-19 to come back, which we are not hoping. Everybody knows that there is a substantial impact on healthcare service provision, mainly on testing and treatment, so delays to diagnose and treatment. I'm going to talk about this in a minute. There is a report, there was an early report by ICD, by Dazia Ismail and Harry Moultrie on the reduction in expert testing, which suggested that in the early phase, due to level 5 restrictions, there was a 48% average weekly decrease in TB expert testing volumes. And the assignment that we are currently presenting the results of was discussed in this early phase of the pandemic. And the idea was to use data as they are gathered over time to get a more complete picture of what's going on in these years of the COVID pandemic, and also to understand the baseline for potential recovery measures. So this was the early idea. Unfortunately, it took quite a while until the data were available, so we did not have much time for this analysis. But I think today this is the first comprehensive account for South Africa to estimate the impact of these restrictions on TB healthcare services and also on TB epidemiology. So the first estimates that for this period, and we're very glad to share that with you today. Just before we talk more, just to give a little bit of an overview of what we are expecting in terms of impact on healthcare service provision. The first is that these measures have an impact on the people accessing healthcare services. So there was a reduction in accessing healthcare, which resulted in fewer visits to particularly primary healthcare, delays obviously in diagnosis and treatment, but also fewer follow-up visits and fewer medication visits potentially. The second is the enormous shift of healthcare resources towards the COVID pandemic resulted in reduced TB testing, reduced capacity for TB treatment monitoring again, and then obviously also important to consider the services for concomitant conditions, including HIV services, provision of ART, which are also important and which are also expected to have a profound impact on TB healthcare services. So this altogether, we expect resulted in a reduction in TB tests performed and TB diagnosis made, a reduction in TB treatment initiations with potential high initial loss to follow-up, and then also during treatment, higher loss to follow-up and higher death during treatment. So this is the anticipation before any data. This is kind of the impact that we expected that these measures would have on TB healthcare service provision. What we, and I want to say this upfront as well, what we cannot really fully evaluate is the impact of reduced contact in the population and contact patterns. So we're expecting that due to mask wearing and due to curfews and lockdowns, there was also reduced contact rates in the population. And this is something that is not yet fully understood. And we've done some analysis on that. But that is a factor that remains uncertain, as well as the potential biological effect that COVID-19 infections might have on tuberculosis. So this is also not something we're looking at today. We're looking mainly at the impact of restrictions or measures to contain COVID-19 on TB healthcare services. If we talk about impact, then we obviously mean the epidemiological impact. And this is some early work that was published in the European Respiratory Journal in 2020. So in the first year of the pandemic, looking at the potential impact that these healthcare services could have on the number of incident TB cases and TB deaths in countries. Here, adapted from this paper by Finn McQuaid, is the figures for South Africa, where they showed that if you have reductions in services by 0, 20, 50, and 80%, you're expecting an increase in the number of incident TB cases. However, at the same time, if we're expecting a reduction in contacts, then this reduction will interact with this effect of reduced healthcare services, as you can see here nicely. So you see the higher the reduction in contacts, the lower the numbers of incident cases and deaths due to reduced transmission. However, the higher the reduction in services, the higher the potential number of cases. Now, this model was really a conceptual work without any data to inform these models, just to explain what to expect. And now we're kind of relating to this modeling work because we have data now, very useful data from South Africa to actually look more closely into these effects. The aim of this assignment was to assess the impact of the COVID-19 epidemic and nationwide lockdowns on tuberculosis healthcare service provision and epidemiology in the public sector and at the provincial level in South Africa. And in parallel to this assignment, this think tank assignment, there is a larger project funded by a BRICS mechanism from the BRICS countries, where we're currently collaborating with Brazil and India to look at the country level in all three countries, South Africa, India, and Brazil, to look at the impact of reduced healthcare service provision on TB epidemiology in all three countries. So this is sort of a parallel project, and the idea of this think tank assignment was really to look deeper at the subnational level and to look at how reductions in or how COVID measures and reduced healthcare services at the provincial level would likely impact epidemiology. So data sources, we had aggregate TB testing data from the NHLS and NICD for the period January 2017 to June 2022. And then we had TB treatment data from the Health Informatics Directorate of the National Department of Health, treatment initiations from the 1st of January 2018 to December 2021. So we're covering the pre-COVID period here and the first 2 years of the pandemic for treatment initiation data. And for the treatment outcome data, we have data from the same beginning from 1st of January 2018 to the end of December 2020. So at least the first few months of the COVID-19 pandemic to look at treatment outcomes. For objective 1, we aim to investigate trends in TB healthcare service provision prior to and during the COVID-19 pandemic across the 9 provinces of South Africa. This included the disaggregation of TB case finding outcome data by age, sex, and HIV with stratification by drug susceptibility. So this is the descriptive analysis, and we've gone a lot more into detail here. To look at trends or describe trends at the subpopulation level. And as I mentioned, we are focusing more on the modeling part in this webinar today for objective 2. And this was to estimate the extent of the COVID-19 pandemic and related disruptions to healthcare service provision at provincial level. And then we use the estimates for that come from this first part to estimate the epidemiological impact of these disruptions at the national level in South Africa in terms of the impact on incidence and mortality. Methods towards objective 1, we conducted a descriptive analysis. I mentioned this of key TB indicators over time, and including the lockdown levels. We looked at testing and treatment patterns by province, age category, sex, and drug susceptibility. And then there was a before and after comparison, 12 months preceding the first COVID-19 lockdown compared to the first 12 months during the COVID-19 pandemic. And this work was led by Mohammed Osman, who I think joined as well today, and gives a much more in-depth view of what happened in different subgroups. However, there are several limitations associated with this comparison, before and after comparison, because of other trends, secular trends, seasonal trends that need to be taken into account. But these results can be found in the report, and we're going to focus in the following on the modeling part, objective 2. Objective 2, we ask ourselves, total 2 questions, 1A, 1B, and 2A, 2B. The first is we were interested in understanding to what extent COVID-19 related lockdowns led to TB healthcare service disruptions at national and provincial level. So mainly we looked at expert tests conducted and the numbers of people initiating TB treatment, and then obviously also the unfavorable treatment outcomes. And then question 1B related to the positivity rates of expert. So in other words, what is the percentage of expert test results that were positive over time, and how did this change with the the onset of the COVID-19 pandemic? This modeling work was done using an ARIMA time series forecasting model, and I'm going to talk more about this in a minute. In the second part, we're using results from the first question to inform a transmission dynamic model to answer the question about what is the epidemiological impact of healthcare service disruptions on TB incidence and mortality. And then the second question is, what is the potential impact of TB recovery measures? Unfortunately, we did not have data on actual recovery measures, but we did some additional modeling to understand what could be achieved, what could be accomplished if some of these effects were mitigated early on. So for towards question 1, we used an ARIMA model. This is an autoregressive integrated moving average model for time series forecasting. So this is a well-known series of models that allow for forecasting with information from prior years. So in the model, you have the model accounts for a trend over time, so a secular trend. It accounts for seasonality, and it also accounts for random behavior of data. And it uses data from a certain number of time points, in this case from the pre-COVID era, to estimate the expected numbers of tests performed, people initiating treatment, and also the expected outcomes if in the absence of COVID. So if you take the time trend before COVID, you obtain results that equal expectations in the absence of COVID. And for the model, we compared these predictions or these forecasts in the absence of COVID-19 to the actual observed trend in healthcare service indicators during the time of COVID-19 to estimate differences and describe how COVID-19 likely impacted these indicators for healthcare service provision. So I want to give an example of the ARIMA model and its outputs. You can see here on this graph a range of data points that are connected through a line. Each of these data points on the left-hand side up until March 2020 represents observed data in the pre-COVID period. So these are the data points that are being used for the modeling, and the ARIMA model produces then a forecast. So this is a prediction of what to expect during the time of COVID, but in the absence of COVID-19. So just if the trend from the pre-COVID era is forecasted, you can see here in blue, this is the forecast in the absence of any additional effects resulting from lockdowns from COVID. And you can see here that there is some sort of seasonality. We see these dips usually during the end of the year. In December, this is number of expert tests performed. People think this has very much to do with people traveling more often during the holiday season. And you see here these decreases every December, which I think are very interesting. And the model expects, or in the forecast expects, that these will continue. The model also takes slight secular trends here into account in the number of expert tests performed. So you can have a slight decrease in the overall number of tests performed. This is all captured. What you can then see is the observed data during the COVID-19 period, and you see here this dip occurring. These are the actual observations during the COVID-19 pandemic, and then the model uses these differences between these observed points and the forecasted points to estimate what the impact was of health services of COVID-19 on health service disruption. So the model calculates a percentage difference between observed and the forecasted data. You can see this here on the right-hand side. And this difference is to interpret by saying we are, for instance, if we take the reduction in April, so these are monthly data, if we take the reduction in April, then we would expect a 30% reduction in expert tests performed relative to a scenario in the absence of COVID-19. So you kind of get a sense of the percentage decrease in testing compared to a hypothetical no COVID scenario. And that's important for understanding. This is the way we estimate reductions in testing, reductions in treatment, but also increases in unfavorable treatment outcomes. For question 2, we are using a compartmental transmission dynamic model of tuberculosis in South Africa. This model was developed at our modeling partnership at CECIMA and the Desmond Tutu TB Center at Stellenbosch University. It is being used for a larger project funded by the Gates Foundation to look at the impact of novel diagnostic tools on TB epidemiology in South Africa. The model consists of 11 compartments and 9 subdivisions for HIV infection progression and ART. It is implemented as ordinary differential equations in R, and it allows for projections until 2035. And we use this model to insert the findings from the first part, from the ARIMA model, to look at how reductions in testing and treatment and increases in unfavorable outcomes would impact on TB epidemiology. So this is the model, and I want to use a short moment to walk you through. This is a compartmental model. The population in South Africa is assumed to be allocated across these different compartments. So you have people who are susceptible to infection but not yet infected. Then we account for primary infection, latent infection, according to whether it was recent or distant. We have subclinical disease versus clinical disease here. We account for care seeking, and we have a care cascade incorporated here that people who seek care are awaiting diagnosis. They may move on to treatment, or they may be lost along the care cascade, or initially lost to follow up, and then they end up in a disease stage here for people who previously sought care. People who are on treatment can complete that treatment and lead to a recovery stage, or they can the treatment can remain incompleted, which results in a higher risk for relapse, so a high risk recovery stage here. And then people can enter these stages again conditional on relapse or reinfection as well. And then the model is mirrored. We see these different HIV subdivisions here: HIV uninfected, infected with different stages of CD4 count representing the progression in disease. And then at each stage, we allow for ART initiation and then additional subdivisions for people on ART. And you can see here, we have different ways to tweak the model. The transmission reductions in contact rates lead to reduced transmission. We can reduce the rate at which people access care, so reduced access to diagnosis. Then the increase of the probability of incomplete treatment, so we can reduce the treatment success here. And this is how we managed to translate the effects of COVID-19 and lockdowns on healthcare service disruptions into this dynamic model to estimate TB incidence and mortality. What we're not showing here is the impact on the increase in mortality due to delayed care seeking, but also during treatment due to reductions in treatment monitoring and potentially reduced visits for picking up medication. So the model is calibrated to 9 to 10 different targets. So these are data from the overall population in South Africa, also on HIV prevalence and ART coverage. We have additional targets for TB incidence, mortality, case notifications, and then we also incorporate the data from the most recent TB prevalence survey at the national level in terms of TB prevalence, percentage subclinical TB, and people who were found with prevalent TB who previously sought care. In terms of the model scenarios, we looked at different scenarios. The first is we have the hypothetical no COVID scenario, to which we compare all estimates. So this is assuming that there was no COVID-19 pandemic and no disruptions. And then we have different pandemic scenarios, starting with a scenario where disruptions occurred during 2020 and 2021, and we're assuming that in 2021 these reductions were slightly less compared to 2020. For instance, for treatment outcome data, where data for 2021 were not available. We then have a pandemic scenario 2, where we also assume that transmission was reduced by 20, 30, and 40% due to less contact in the population. We then have pandemic scenario 3, where we assume that the same thing has happened as in pandemic scenario 1, but there are continuous disruptions at the 2020 level until the end of 2027. So this is sort of a prolonged COVID-19 scenario here that we are taking into consideration. Pandemic scenario 4 assumes that the 2020 levels remain in 2022, and then followed by a second hypothetical pandemic wave with similar health service disruptions between 2023 and 2025. So these are different realities or different possibilities of what could happen in the future to give us some estimate of what's going to happen to TB. And then last but not least, we have a few scenarios for recovery, assuming that there was an increase in people accessing TB diagnosis, increased by 10, 20, and 30% higher than those achieved in the pre-pandemic time, 2019. So this is assuming that there are substantial efforts not only to mitigate, but to increase case finding as part of the new NTP strategic plan. So the analysis strategy, obviously, there was a huge collection of TB indicator data that were provided to us. We used these data to describe trends over time and in consideration with lockdown levels. This is the work led by Mohammed Osman. And then we used the ARIMA model, like I've shown, to estimate disruptions to healthcare services. We're using percentage differences to describe observations versus predictions or forecasts of TB indicator values. I've mentioned the timelines. We're using best estimates, and we're presenting 95% uncertainty intervals from the predicted intervals. Then the transmission dynamic model, we looked at projected trends in TB incidence and mortality for these various scenarios. We calculated the cumulative numbers of additional or averted TB cases and deaths between 2023 and 2035 relative to the no COVID scenario. So this is giving us an idea of what the change in cases and deaths is relative to no disruptions due to COVID. And then we're using the mean and 95 uncertainty intervals from 1,000 simulated model trajectories from the transmission dynamic model to obtain forecasts or estimates of incidence and mortality until 2035. This is all from the methods, and I'm handing over to Abigail to present the key findings.
Thank you, Florian. Yeah, thank you. Okay, so this slide here is showing a summary of Objective 1's data, and it shows the key TB indicators over time. So we've got number of extra tests conducted, extra positive tests, number started onto TB treatment, TB success, and TB deaths. So starting at the top, we've also got from 2017, as mentioned, the number of expert tests conducted all the way to the June 2022. And you can see in this, as Florian had mentioned, the seasonal dips in December And then we see once we get to March 2020 and we start seeing the key lockdown levels being plotted here vertically, we've got, we can see declines that have happened with TB testing. Similarly, you see declines happen with the number of exit positive test results. TB treatment initiations, we've got data from 2018 until December 2022. Here you can also see drops occurring within treatment initiations during lockdown, as well as declines in TB success and TB deaths. There's also declines there, but not so much. So next slide, please. So that TB indicator data is what we had mentioned fed into the REMO model analysis work. So Florian had shown you and I described you an example of how we conducted this. So I'll start on the top. So the top left, number of expert tests performed. This is exactly what he had shown you, where you can see the observed data over time in the white dots, plotted against the AREMA forecasts in the blue dots. So then we're able to see from March 2020 onwards, what was the difference between what was forecasted and what was actually observed during the time of COVID-19. So looking on the top right, this is where we've quantified as percentage differences between those observed data values and predicted values. So number of expert tests performed, you can see declines all the way up to a 50% decline within the early parts of 2020 and the harsh lockdown levels. And we see some recovery towards the end of the graph plotted, and so that's around starting in 2022 we actually start to see some recovery happening with an expert test performed. Going down to the middle two panels, this shows the number of expert tests found to be positive, so this is percent positivity. We can see again that there was, if we go to the middle right panel, we can see an increase in positivity happening, especially in the beginning parts of 2020, where this percentage difference is sort of declined, and we don't see much difference between observed and predicted values within 2022. At the bottom, I've looked at the TB indicators of percentage resistance results, and we didn't really see much difference between observed and predicted values. Next slide, please. We then looked at TB treatment initiation data. So this is showing the number initiated onto TB treatment, otherwise known as case notifications. So looking at the top right graph, this is where we plotted percentage differences. So we see already in April 2020, about a 20% decrease in the number of case notifications, declining all the way to almost 50%. And slowly this number is recovering with over 2021. We don't have data for 2022 for case notifications, so that's why we've plotted this till end of December. And on the bottom graph, we're trying to have a look at were these drops in case notifications due actually maybe just due to reductions in TB testing. So here we have plotted the percent differences between observed and predicted. So for tests performed and treatment initiation. So this graph shows us that the reductions in the number of tests performed probably led to the reductions in the number of case notifications that we see. Next slide, please. We then looked at TB treatment outcomes. So just to clarify that we defined reported outcomes as that being success, failure, death, loss to follow-up, and not evaluated. So those are the outcomes we had. Starting with the top graph, we've got here I've plotted percentage not evaluated amongst all reported outcomes. And if you look at the top right, this is where we're showing if there was any difference between observed and predicted. You can see it's not a very significant difference. But if we look towards the end of the reporting period, so we're looking at about September, October, November, December of 2020, we could see quite a steep increase in number or the percent not evaluated amongst all reported outcomes. This might be to a sort of time lag bias. And on the bottom, they've got percentage treatment success amongst all reported outcomes. And here we actually observed quite a drop in treatment success, where you can see from 2020, there was a much lower percent treatment success compared to what we would forecast it to have been. Next slide, please. Here is looking at unfavorable TB treatment outcomes. So unfavorable outcomes are defined as death, loss to follow-up, failure, or not evaluated. So in the graphs on the top, we've investigated percentage unfavorable outcomes among all reported outcomes. Here, when you're looking at 2020, you can see the observed dots in the white, much higher than what we had forecasted there to be. And this was about a 20% increase in percent unfavorable outcomes throughout 2020. On the bottom of noteworthy, one of the outcomes was TB deaths amongst all reported outcomes. And again, you can see that we observed a lot more versus what we had predicted there to be. And this was about a 20% average of observed, or 20% more cases, TB deaths were observed than those predicted. Next slide, please. So this is a summary where we have taken the, like the previous graphs has shown you the percentage differences every month. And then we aggregated these to get a sort of annual estimate. So for 2020, we have an annual estimate, which is aggregated from April to December, because obviously that's when the COVID-19 pandemic had started. So this is a summary measure that, first of all, number of expert tests performed. In 2020, we saw a 32% decrease compared to what we'd expected to have seen. We had seen a 12.3% increase in positive test results. And then we had also of noteworthy seen a 21.4% increase in proportion death amongst unfavorable outcomes. We also had some outcomes for 2021, but as I mentioned, we didn't have TB treatment outcome data for 2021, so we were only able to quantify number of expert tests, testing data. And here we can see that, for instance, the estimate of 32% of number of expert tests performed declined to about an 8% decrease in 2021. So we were not seeing as much of an effect within 2021. Next slide, please. So this graph just summarizes what I'd shown in the previous table, where you can see there's a bar chart, the various TB indicators shown. So the top bar graph shows for 2020 the different estimates and which were most affected. So as mentioned, of noteworthy was decreases number of expert tests performed and treatment initiations, and we saw increases in test positivity and then unfavorable outcomes, and specifically with TB treatment deaths. And the bottom graph shows for 2021 how TB testing was affected. Next slide, please. So that was all at the national level and the impact we had seen amongst all the TB indicators. And now this graph is a very complicated graph, but I'll slowly walk through it. It's showing the results at the provincial level, so how each province was affected based on four main key indicators. So starting with panel A, which is on the top left, number of expert tests conducted, you can see how each province has been affected. So again, when we see bar down, so 40%, so for instance, a negative 40, that means that we saw a 40% reduction in number of expert tests conducted compared to what we had predicted. So here we can see South Africa is shown in the middle of the chart, the national average I just reported on of 32%. And then you can see how each province compared to this. And the blue shows your estimate for 2020 and the green for 2021. So we can see a large variable range across TB and number of TB tests conducted, with Free State showing a very large reductions and Mpumalanga the smallest of the range. And yeah, very high variance. And we can actually see Gauteng and Mpumalanga showed evidence of actually some recovery in the number of TB tests conducted, where we had seen more tests conducted than what we had actually forecasted or projected there to be. Moving on to panel B in the top right, number initiated to TB treatment. We saw declines in all the provinces, again, quite a large variation across them, and you can compare to the national average each province. And yeah, so there was also a large uncertainty around some of these, but yeah, we can compare what's happening in each province, and there was not really any signs of recovery there. Graph C, at the bottom, we've got the proportion or treatment success, so cure or completed TB treatment amongst all reported outcomes, where we also saw declines amongst all the provinces, with still quite variable, but not so extreme, the variance across the provinces. And in panel D, the bottom right, is proportion TB deaths among treatment outcomes, among all reported outcomes. There was quite variation again between the provinces. We had KwaZulu-Natal, Free State, Western Cape, and Gauteng province above the national average. And we see quite high percentages ranging from 42% in KwaZulu-Natal to very small, I think about 0.1 in Limpopo. Yeah, so that's to summarize summarizes the key indicators for each of the provinces, and you can also compare to the national average. Next slide, please. So these are the transmission dynamic modeling results under each of the scenarios that Florian had mentioned. So this was the no COVID scenario, the baseline scenario where we projected TB case notifications until 2030, TB incidence and TB incidence until 2035, and TB mortality until 2035. So this is a sort of hypothetical scenario if COVID-19 was not to happen. And we projected a total incidence TB cases between 2023 and 2035 of 3.7 million, and estimate about 502 TB deaths to occur until 2035 under this no COVID pandemic scenario. Then under pandemic scenario 2, which is where we incorporated the disruptions as from the REMA model. And when we didn't have TB treatment outcome, we're seeing a 50% disruption compared to 2020. Here you can see the impact on TB case notifications. So starting on the left, the solid line is the pandemic scenario versus the no pandemic scenario. We can see the drop in case notifications as one would expect, and then with sort of an increased period afterwards, I'd say as a backlog. Then moving on to TB incidence, we can see a decline, a slight decline happened, and TB mortality, we can see an increase would have happened or happened under this COVID-19 pandemic scenario. Moving on to the next slide. Under pandemic scenario 2, this is where we had the same as pandemic scenario 1, but we also looked at various estimates of reduction in transmission because we didn't have data on this, but we could see how TB case notifications would drop, or if we had reduced transmission, that TB incidence would decline because of reduced TB transmission, and TB mortality would also, we would have the increase through the pandemic, and then a slower or less number of TB deaths occurring if transmission was reduced during the COVID pandemic. Next slide, please. So this was the hypothetical pandemic scenario where we assumed that further disruptions would happen. And here we could see under TB incidents that we're now at a sort of worse off trajectory that would happen as we would if the COVID-19 pandemic was to continue, and TB mortality as well, we would have quite an increase of TB mortality going forward. And next slide, please. So this was the recovery scenario. So the recovery scenario was just a hypothetical where we looked at what if we were able to increase TB case finding by 10, 20, and 30%, and how this would impact TB incidence and mortality. And yeah, so we can see various effects, and that we would be able to sort of improve the trajectory towards the NTB target. So we would be able to speed up the decline in TB incidence and the mortality if we were able to reach sort of the post-pandemic increase in number of people accessing TB diagnosis. Next slide, please. So overall, I think it's important to highlight some limitations of our study. So first of all, the starting point of our data was expert tests done at the laboratory. So we had no data on the rate of accessing primary healthcare or TB screening. So because we started off a number of expert tests, we aren't able to see if declines in testing were due to individuals arriving for like not being able to come to the healthcare facilities, or if this was due to reduced capacity for the tests. So we're unable to describe reductions in terms of care seeking because of this. We also, to highlight that we had aggregated data. So the data wasn't individual level, so we couldn't link individuals between testing and treatment data. So this wouldn't allow us to see any delays in diagnosis So we couldn't account for any delays or disruptions along the care cascade in our transmission model. This is because, because we don't have individual patient data. So this may lead to underestimations of the impact of the healthcare service disruptions because we couldn't quantify any delays to care seeking or along the care cascade. And lastly, TB treatment outcomes are reported using cohort approach. So often it's quite difficult to identify the exact months or dates when TB treatment outcomes are most impacted. This is because outcomes are reported in the month of TB treatment initiation. And lastly, with the REMA model, sometimes it's hard to interpret some of the results when we've got a very small absolute number. So say number lost to, or the percentage proportion lost to follow-up amongst reported outcomes is often quite small. And if you were to compare various outcomes, so say now there's a 0.2% in TB or lost to follow-up amongst reported outcomes, this is quite hard to quantify as if it had changed from 0.2% to 0.3%. That often leads to a very large percentage difference. So it's just often difficult to interpret REMA model results when we're working with very small numbers like percent lost to follow up. I'm going to hand over to Florian now to give the conclusions and discuss some of the results.
Thank you, Abigail. So I want to, in this final part of the presentation, I want to summarize what we think are the most important conclusions of this work. Now, this TB think tank work has enabled us for the first time to obtain comprehensive estimates of how the TB healthcare services have been impacted during the time of COVID-19, and also how these effects will translate into changes in TB epidemiology. First of all, we've seen that there are substantial reductions in the number of expert tests performed, increase in positivity, test positivity consistent with the earlier reports and ICD that we had shown. There is large variation across the 9 provinces, some showing evidence of recovery. Possible reasons for this variation are that less people are accessing healthcare or reduced service provision, more people with severe disease presenting to health services during hard lockdown. So that means that during this time, it's possible that there's a selection of people who are really sick. People who are less sick would not access healthcare, but people who are really sick with severe disease are presented to healthcare services, and hence the increase in positivity. We see a substantial decrease in treatment initiations, most likely also linked to the decrease in testing. We've shown that there is a substantial increase in the percentage of unfavorable treatment outcomes in the outcome cohort in 2020, specifically an increase in the percentage TB deaths amongst the outcome cohort. There's a large range across the provinces that we've shown, but I think this is really important to understand that these lockdowns have impacted on the results of people's treatment outcomes as much as on testing and starting treatment. We've done additional sub-national analysis, but I think that additional analysis with emphasis on specific recovery plans that were implemented would be really helpful, and could this analysis is able to help target resources to provinces with highest needs. So we've established a baseline, but it will be really interesting to see how recovery measures to mitigate these effects over the next few years play out, and the model could be updated to account for these and do additional analysis. Finally, we show that there is a impact of reduced healthcare services on TB epidemiology, with increases in TB incidence and TB deaths. We've just before the presentation just calculated the percentage increase in incidence just for the year 2021. So the best estimate is about 1.1%, so a smaller effect on incidence, and almost a 1/10 increase in TB mortality, so a much larger effect anticipated on TB mortality in South Africa just for the year 2021. However, if you look at the trends for 2035, if we are assuming that the COVID-19 pandemic is now over, then we are expecting an additional 21,000 TB cases and 4,000 TB deaths during the time after COVID-19 until 2035. So this is just the time period after. So we think that with the hopefully the end of the COVID-19 pandemic, there's a relatively small impact towards the trajectory and declines in incidence and mortality until 2035. But this is obviously conditional on no further disruptions. We've seen that in the pandemic scenario 3, that if there are further disruptions, then we will obviously see more cases and more deaths. And we also show that recovery measures, in this case, increased diagnosis, could enhance progress towards the NTB strategy targets, but this remains to be compared with actual numbers from these measures at national and province level. I want to acknowledge mainly Mohammed Osman, who has been co-leading this effort, led the descriptive data analysis, and then obviously other people involved, Suan Mehan at Desmond Tutu TB Center, Anneke Rory also at the center, and then we received a lot of support also from Hari Molchi and Farzana Ismail, who are also co-investigators. We would like to thank the think tank for commissioning this work, for funding this work. I want to just mention we have a detailed report that is being disseminated on these findings that I think will be made available to everyone. We've submitted a poster for the Union Conference, with the title entitled Sub-Country Level Variation in Tuberculosis Healthcare Service Disruptions Due to COVID-19 in South Africa, a model-based analysis. So we hope to present this work at the upcoming Union Conference. We also want to show that as part of this modeling effort, we've recently done a systematic review of modeling studies that have been done over the past 20 years or so to look at the impact of interventions for TB prevention and care in South Africa. So this is a review that just came out in the SAMG that I think is of relevance, and I think we're going to share that as well. And then finally, we will have a dissemination meeting for a larger partner project. Alongside this TB think tank assignment, there's a larger effort, I mentioned this, funded by the BRICS countries, where we're looking at the epidemiological impact and intersection of COVID-19 and tuberculosis pandemics in these 4 countries. And we've done an analysis similar to this also for India and for Brazil. With this, I'm concluding. We have a few minutes left for questions and comments. So thank you very much, and I'm opening the floor to any questions.
Thank you so much, Florian and Abigail. That was excellent. I see in the chat we have a number of questions. Let's start with Neil Martinson, who said, is it TB mortality or mortality on TB treatment? Seems that mortality due to TB may have increased during the harsh lockdowns.
Yeah, so this is a very good comment. Obviously, these indicators do not distinguish causes of death. So this is mortality amongst TB patients on TB treatment during TB treatment, but it's absolutely right. It's difficult to differentiate.
Thank you. The next one is from Russell Rensburg. Excellent presentation. What are main takeaways that policymakers and administrators should note?
This is a very good question that I would actually like to give back to the entire think tank. And I think it is worthwhile thinking carefully about that. My feeling is that, first of all, we can see that TB, COVID-related health service disruptions have cost lives in South Africa and are costing lives. So it is important to think about mitigation, about recovery measures. And I think especially the subnational level analysis can be helpful to better target initiatives, to focus on provinces and areas within South Africa where these effects of lockdowns have hit the hardest, where the population, especially people with TB, are suffering the most from these consequences. And I think using these analysis as an entry point to better target and to intensify measures in these areas, I think is really important. But I really want to not answer that question too much, because we are all, like, you are all the experts, and it would be interesting to hear from you what you think should be done based on these findings.
Thank you, Florian. Just in the interest of time, let's squeeze this last question in, and then maybe for those that are able to stay on the line, we can open up to other views on where to take these findings. The last question here is, are you planning an age stratified approach to these models, and how were children impacted compared to adults, for example?
Yeah, so this is a very good question. For the we've done in the descriptive analysis, we've looked at age as well. We have not considered age in the forecast models and also the transmission dynamic model, because the numbers are smaller and it is difficult to describe these trends. If your uncertainty is very big, if the numbers are smaller, so I cannot answer that question yet. But we will look into that, especially for children. I don't know if Mohammed is on the call, if you want to say a little bit about subgroup analysis from the descriptive part. Mohammed, can you hear us?
Hi, thanks, Florian.
Doesn't-
Sorry,
Yeah.
I didn't have access to unmute my mic, so I was actually typing a comment. But as you've said, I think the report that you highlighted towards the end shows some of the changes that we saw. Specifically, we looked at pediatrics and adolescents. And there was some differences in how expert testing changed, and also the notifications occurred in those specific groups. And then there was also, very interestingly, a difference by sex, with a bit of a greater recovery in the one rather than the other. And so some of this is in the detailed report, and so people would have access to those numbers. And I think as we start to put together the findings and get it to ready sort of for publication, we will be showing those, but it will be descriptive without the benefits of the ARIMA model for the age and sex analysis. Thanks.
Thanks, Mohammed. If there are any more questions, please do type them in the chat. And then I think we're going to just, in the meantime, pass the mic back to the audience to say, other than what Florian's already mentioned, are there other places that you think these findings would be applicable in terms of policy? If you can, I do believe you can raise your hand, and then we can unmute you. If you're unable to raise your hand, do feel free to write it in the chat. Well, Florian, I think we'll keep that discussion open. We will include Florian and Abigail's emails in the chat for everyone who participated if you have some thoughts you'd like to share with them. And do keep an eye out for future presentations and publications on this work. I'm just going to hand back over to Ntogozisi to take us out. Thanks very much.
Okay, thanks, Jody, and thanks, Florian and Abigail, for the great presentations. And much thanks to everyone that attended. Please, as Jody has indicated, there are more installments coming. The next session will be up in May, so we will advise of the date and the topic of what we will be discussing then. Otherwise, thank you so much. And we do apologize for Priya. She had to drop off to attend something quite urgent. But otherwise, thank you so much. And we will until we meet again in May. Thank you and bye.